I see several of my students here. Where do the most successful students sit in the classroom? Andrew? Can't believe one of my own students is embarrassing me like this. I want to call on somebody I know will get the right answer. Mary James? The second row. Why do you think that is? Not the first row, but the second row. Eye level. When I'm standing here, I'm looking at Barry and your eyes, right eye level. So you get to know people better. And there's a strong correlation between how well the faculty and the student knows each other and how well they do in the course. Okay, enough about that. I'm not going to say anything about the biography of our speaker. Todd Meredith is a Georgia Tech alumnus from IE in 1997. I know a lot of his classmates. It's the first time I've met him. But I'm not just dumping the work on him. I'm doing that strategically because I've spoken here at Impact twice before I joined the faculty back in the days when I was a CEO and wore socks and everything and dark suits. And I asked Terry Blum, Dory's predecessor, what should I talk about? And she said, yourself. And I said, that'd be boring. Nobody wants to hear that. And she said, yes, they do. They want to know about how you got from the College of Management in 1971, 51 years ago, to be a, well, it wasn't 51 then, to be a CEO. And that's a circuitous. They have a crazy pathway. How did that happen? So, Todd, when you were a freshman here, did you ever think that you'd be sitting here talking to all these distinguished students about healthcare real estate?
No.
Well, then what was your plan?
So I actually came to Georgia Tech in the fall of '92, and I was an architecture major. So I was telling Bill, you know, I'm from the Kansas City area. So why in the heck am I at Georgia Tech? But the story goes, my dad was a career Army officer. And so I'd grown up moving around everywhere. And we actually did spend some time in Atlanta, and my dad just loved it. He said, there's so much, it's warmer here, it's beautiful. He loved it. And so he always held sort of a special place, but that was about 2 years of my life when I was a little kid. And so we move around, and we're in Germany when I'm a senior in high school. And I'm at an American high school, but having a wonderful experience in Germany. And my dad said he ended up being an engineer is his career. He was actually an architecture major. You can see the influence. And he was always drawing, and he was always taking us on tours of buildings and so forth. So there was a little inspiration there. So anyway, he had all these engineers come through, and he said, boy, these Georgia Tech engineers, they really stand out. They're good. They're great. So it just sort of planted that seed, and that in Atlanta. And so I applied, I think, this is the difference in my day, and I'm sure Bill can say the same thing, versus today, how many schools people apply to. I think I applied to 3 schools: University of Kansas, Iowa State, and Georgia Tech. Which one doesn't look like the other? And I got in, which was great, and felt very fortunate, and off I went. My parents flew in with me and dropped me off, and the rest was sort of history. But and this is interesting about the speaker series that you have at Georgia Tech, and we had it back then, and I actually attribute my switch from architecture, I actually was a management major. And so I switched after I guess we were on the quarter system then.
Oh, that's right. Your wife is an IE.
My wife's an IE.
And now she's a physician. Go figure.
Yeah. She's the one that's better at the math and science. I was, architecture and management.
That's all right. We hire those people.
That's right. So anyway, so I ended up had a speaker series in the architecture school, and all these architects from around Atlanta and places would come back, alumni. And it was a great exercise to for me to figure out, well, what does life look like? Just like this, what does life look like when you graduate and you do this profession? And I will say it sort of burst my bubble. I think I had this vision of an architect as, just sort of drawing beautiful buildings in the skyline of Atlanta or other big cities. And you find out it's a little different than that. There's a lot of work on the path there, and that's true of everything. But I just kind of soul searched and said, I don't think this is exactly what I want to do. So I switched over to the management school. And I guess when I was there, it was a management degree. Now it's a business degree.
Mhm.
I think it was industrial management.
That's what it
before
was.
me.
That's what mine is.
Yeah, exactly. So it's evolved over the years, but I switched over and I just started exploring, business and really got into it. So I did have this little sort of seed or kernel of interest in real estate, really from a design perspective, had that influence. So I guess there was a nugget in there, but then switched over to the business school, started taking things like accounting, and finance and economics, some real, basic intro courses, and really liked it, really enjoyed it. Like a lot of Georgia Tech students, I certainly enjoyed the math and science aspects of things, the analytical side. So really enjoyed that. And so it kind of flourished from there. So that's sort of how I switched in to the business side of things. And no, I never knew that I would switch over to actually going into real estate. I went into banking, as you heard. That was my first stop after school in '97. I spent, I guess, about 4 years in banking. And for me, talk about a great career step. It was kind of random. Georgia Tech wasn't known, or I don't think it's necessarily a hotbed of investment banking recruitment, because that typically is sort of your business school focus. I'm sure some of the MBA students might see some of that. Maybe I'm wrong. I don't know how it is today, but I had a professor in finance, and he left right after I did. And I can't remember his name, but he had connection with some alumni, and one particular alumni was looking for some bright young students to come over and sort of help him build this practice at a firm that was based here in Atlanta, based in Charlotte and Atlanta, called Interstate Johnson Lane, small brokerage firm. It's actually publicly traded.
Yeah.
Ended up selling out to, now would be rolled up into Wells Fargo. So I got about 4 years of great investment banking experience, which was great. Just put all that finance and economics to work. So that was kind of the base of how I got there.
Yeah, and many students of mine have gone into banking because they have good training programs, and you get to see every other industry.
Yes.
So it's a good starting point. It really is, especially for people who are not quite sure. Some of my students are passionate. I'm going to be a physician. It's great. And I have 80 former students now who are in medical school, residency, or 3 are in practice. So let's get right into it. And let me ask you this, from our healthcare perspective, real estate's just a thing. We outsource it. We don't spend any time thinking about it because that's not our core competency, whether you're a hospital administrator like me, or certainly a physician, nurse, or a direct caregiver. You don't want to think about real estate. But in previous times, they did have to think about it, because the model had been a physician would graduate, get from medical school, go through their residency, maybe a fellowship, and then set up a private practice and hang out a shingle. Well, they had to know something about real estate. They had to do something, go find a broker or something to do that. Well, 2014 was a tipping point. In 2014, or since 2014, more physicians work for hospitals than they do themselves. So it used to be that physicians were small business people, sometimes not so small, but they would typically start out with a single practice, and then they would get some partners so they wouldn't have to take call every night. And then gradually they became large practices, and then they were mergers. But healthcare is really one of the last industries to merge. I mean, you think about 3 legacy airlines, 3 cell phone companies, 3 big national banks. And in real estate, Barry, I think that there's a dominance of a few firms, Jones Lang LaSalle, CBRE, people like that. But healthcare is still in the process of consolidation. Emory, Wellstar, and Piedmont are growing like weeds, and smaller hospitals in outlying areas are becoming part of their systems. It's for the usual reasons, economies of scale and access to capital and all those kinds of businessy things. But that had to make a big change in your practice, because you're no longer saying, well, I got to watch this person's coming out of their residency. They're going to want to start a practice in Nashville, where you're based. So I'm going to keep my eye on them. They were a Vanderbilt graduate from medical school. They went to Duke for residency and to Harvard for fellowship. Now they're moving back home to Nashville. I got my eyes on them. But that's kind of not the way it works anymore, is it?
It's really become a big business. To
Yeah,
the point.
it's a
really
big-
consolidated. It's interesting. There's a lot of dynamics in there, and I think you're exactly right how that industry has matured. And you're right, in the last 7-8 years, it's really accelerated in terms of the consolidation of physician groups, along with big health systems providers, which include hospitals. And hospitals have been on a race over that same time period to really diversify their businesses from just being what you think of as a hospital, which is, a tower with beds and doing surgeries and really treating high acuity, care, providing that high acuity care. And largely it's a place you want to avoid. Whereas I think a lot of health systems have really raced to build out what they call the outpatient side, which is the physician practices, where you go see your doctor for well visits and follow-up visits, pre and post surgery, those types of things. Things that hopefully keep you out of the hospital,
Right,
is really the objective. And so you've seen to the same effect, you've seen health systems, especially the more consolidated, more aggressive, progressive systems, like the ones you mentioned here in Atlanta, have really raced to tip more of their business to come from that side, the outpatient side, rather than the inpatient side. So inpatient is the overnight beds in the tower. And there's a whole different regime for how they make money in that setting versus the outpatient side. So our company, Healthcare Realty Trust, was started in '93, really on that premise. It was early. It was real early days. But it was this idea that some of the reimbursement trends had been reformulated in those days, even earlier, to really influence that shift. And it was the really early days of it. And so our founder, a big mentor of mine, he's passed away, but he, was really in the epicenter of some, what I would call progressive healthcare minds. There's great healthcare in any city. But
Nashville is a beacon.
It's kind of a beacon of healthcare, especially for-profit, what I would call sort of your more progressive for-profit systems that are looking beyond their community, let's say, or their region, their state, and looking at how do I develop, a very large national, even international scale healthcare delivery company. And the real progenitor of all that is HCA. If you've heard of HCA, they are a nationwide and international hospital company. Great company. They're really known for really being at the top of their game, especially as it goes at for-profits. Now, they're a very different type of company than Wellstar here or Emory. They're not an academic medical center, although that's changing and sort of beginning to evolve. So we've seen all that grow up, and we've had to evolve with it. And so we were in the early days of that business on the real estate side. And if you go back to the '90s, real estate was essentially a financing for these hospitals. And it was really what you just said, Bill, about how they would recruit doctors. So the hospital took care of all that recruiting, and they didn't employ them, but they would try to help these doctors come out of their residency or their fellowship and come start their practice. They might guarantee a little bit of income as they get started. And they would draw them in, and they would say, hey, we've got a medical office building. We're paying rent on the whole thing. We'll give you a suite, and so we, as a real estate company, really were just financing that building with a lease, single lease with whether it was HCA or Wellstar or Emory. Well, it evolved to where, and so that really sort of meant that REITs like us, so real estate investment trust, which is what we are categorically, it's a tax advantage structure for real estate that's publicly traded. And so you essentially saw it evolve to where we became a real full-fledged operating company. We didn't even manage the properties. We had really a overhead of corporate staff, and that was about it. We collected rent. We made investment choices and we collected rent. It was pretty simple. We call that kind of the net lease model. There's not a lot to do or operate. You just collect rent and you arrange financing. That's basically it. Well, it's evolved very much in our industry, specifically in medical office, but others too, where we actually run our buildings today. And instead of having one lease, let's say we have a 100,000 square foot building and the average tenant's 4,000 feet. So we might have 25 tenants in our building. And it might be that one single doctor, which is pretty rare today, who comes in and leases 1,500 square feet, or it might be Wellstar, who has a 30,000 square foot ambulatory surgery center, and then an imaging center next door. And it's gotten much more complex since then. And now what you see is, okay, now that physician group is no longer a single physician. They actually built up, a very large practice. They've got 20 locations around Atlanta. And then Wellstar finally realized we need to buy that group. So then Wellstar buys the group, and they kind of make their ecosystem work in terms of having those physicians in the buildings, putting in all their locations, extending Wellstar's sort of reach and market share. So we have navigated that by sort of expanding our real estate approach, which we're much more hands-on. We operate the buildings. So we have property managers on site, we have maintenance staff on site, and we have regional folks that oversee that. And maybe I'll just step back and give a scope of sort of where Healthcare
great.
Realty is as a company. We are publicly traded. We actually became publicly traded through an IPO in 1993, my second year at Georgia Tech. I was clearly not thinking about that business at the time. Had no idea it existed. It was, if you look back to the real estate world, the real estate world is still today largely owned by private companies. It's still the majority private companies. But REITs really took off in the early 90s. 93 was kind of the big IPO year for a lot of real estate companies. And that has since flourished. It's really taken off. And today, and I say today, the market, as you've all watched, has been going down rapidly, including real estate, with interest rates rising and inflation. But just to give you a scope, there's probably 150 real estate investment trusts that you can buy as public companies today. There's even more than that, but ones that you probably would consider investable, 150 or so. And it's probably $1 trillion to $1.5 trillion of equity market value. That's a lot, but do remember Apple is, what, 2.5 trillion? So Apple's bigger than all these REITs, which is kind of true of a lot of things, but it's really become a large space unto itself. Healthcare Realty started out, I think, about $125 million of properties. So relatively small in hindsight. I'll fast forward to about a year ago, we got up to about a $5 billion market cap is where we've come to. And that sounds like a lot of growth, but that was, almost 20 or almost 30 years. So, it was actually a reasonable pace of growth. We had a lot of competitors who went to 20, 30 billion. So we were much more of a steady paced growth, and we stayed focused in our area of medical office. A lot of our peers do senior housing and inpatient rehab and all kinds of different asset classes, but we've stayed true to exactly what we think we're best at, this medical office sector. And I think it sort of stands out that we have deeper knowledge of our space. We understand and really relate to this physician experience, the hospital experience. I think we've gained that reputation because we've stuck to what we do. And I will say, I was talking to Bill about this, I have a little secret advantage in that my wife is a physician. She was an IE. I met her at Georgia Tech. She was a freshman. I was a junior. It felt like a big gap at the time, but it was great. And her family was worried. She was too young to be meeting some guy, but it worked out. And I followed her I was in that banking job, and she got into medical school at Vanderbilt. She was always pre-med. She was one of these people that said, from like 5 years old, I'm going to be a pediatrician. That's what she did. And so she took an interesting route. So she came as a chemical engineer, like me, switched to IE, which I think, frankly, is probably the best degree you can get. I mean, through and through, I think IE is a phenomenal degree. I mean, there's lots of great degrees, but I think it's just such a great quantitative, almost applied math type degree, and it applies to so many things. And so I'll say it's influenced my daughter's applying now. She's a senior and applying for IE. So we'll see. We're slightly biased. We like to see.
I advise a lot of young people to come here, go in undergraduate IE, and then get a Scheller MBA.
Exactly.
That's a formula for success.
It's a very powerful combo.
So Todd, the role model for this vertical integration that Barry and you can articulate well in the real estate industry. In healthcare, it started in 1937 with Kaiser Permanente.
Yeah.
And they have, as my students can tell you, a completely vertically integrated system in California, not yet in Georgia. They've got a big footprint here, but it's all outpatient. But in California, they have the insurance company, the hospital, the doctor's offices, the imaging facilities, everything. Do you work with them?
We do a little bit, but I would say it fits the model you just described. We are in California in a fairly large way in our portfolio. We're probably in 35 states, I would say, from all over the country, from Hawaii to the Northeast, and heavy Southeast and West, kind of the Sunbelt growth areas. But Kaiser is a unique animal.
Yeah, they are.
To your point, they've done well. It's certainly a very efficient model. I think their view is they like, and this is, just sort of different philosophies on real estate. This is true outside of healthcare, but even in healthcare, of philosophy of they like to own their buildings, especially if they're
I see.
critical. Now, outpatient, we do run into them and they end up sometimes being tenants in our buildings for their outpatient services. Colorado is a good example of a place where we have them as tenants there. And same strategy in Colorado as Georgia. It's very outpatient. And up in Seattle, they have expanded up there. They bought a group health, which was another small version of Kaiser. So we did definitely work with them. And we have talked with them at the corporate level about owning real estate, but they've done well and they have a very low cost of capital.
Well, let me ask you this. A lot of these students are planning to become physicians. And so say when they finish their fellowship and they're in practice, they're in one of your buildings, but it has the name on it, Wellstar, Emory, Piedmont, whatever. So as far as they're concerned, it is a Piedmont building, but it's really not, it's yours. But if they have a problem, say the internet goes down or the toilets aren't flushing properly.
Air conditioning.
Yeah, air conditioning. They're not calling somebody, they're calling Piedmont, or they think they are. Does that work well? How does that work?
Yeah, I think it's evolved. It's evolved to where, and it depends on the health system. We do collaborate very closely with, for example, a Piedmont or a Wellstar. And I'll make it a little more tangible here in Atlanta, up in Marietta, Kennestone, their Wellstar's main hospital. That's really our biggest concentration in Atlanta. We own several buildings around there. And I think it's pretty well understood now by tenants in the building, whether they're Wellstar employed physicians or they're independent. They get to know us and, they understand, oh, we're calling Healthcare Realty and I will say most of the time we're managing and operating our properties. There are some times where we'll partner with a local operator. Here in Atlanta, we actually partner with a firm called Meadows & and they're a very successful local real estate operating company that developed great relationships with health systems over the last 20 or 30 years. So we bought a portfolio from them and agreed to say, hey, you're doing this really well. We don't necessarily need to replace you. So I think it's evolved where in most cases, they know they're calling the landlord. It does get a little confusing when you're building, and this is what we like to invest in, when the building is so intertwined with the hospital that as a patient or even a doctor, sometimes you don't know when you're in the hospital versus when you're in the medical office building. And the reason we like that, it clearly is because that's important real estate. That's strategic real estate that should have value that lasts. And that hospital will always want to make sure that that asset, that building is fully utilized. And so to us, from a value standpoint, it has more value. So those lines can blur and we coordinate with, and you think about hospitals, I mean, that's like a little city.
Yeah.
And the maintenance staff at a hospital, is
They're part of the team.
They're part of the team and they make things happen. And so our people, coordinate. And sometimes our systems are overlapping.
Without getting in the weeds, that's why I want to focus on that a little bit more because we emphasize that it's more than a doctor. A doctor can't do surgery by himself.
It's a huge
it's a team effort, including the guy that makes sure the air conditioning is working. And that's what I try to get across to students, that there are many, many ways to be in this $3.3 trillion industry that's growing and is pretty recession proof and inflation proof. It's going to keep expanding as more and more of our disposable income goes into healthcare because we want it to. We want the benefits of it. But we don't have to be physicians, nurses, occupational therapists, et cetera. And hopefully you're getting your eyes open saying, oh, there's this thing called healthcare real estate. Well, how interesting is that? Take Barry's course and you'll learn more about it. And so this whole thing about if the physician says the air is too hot in here, and he says to his nurse, call Piedmont and tell them to fix the air conditioner. And then some guy shows up with your uniform on. That's kind of a problem. Do you ever brand your own people with Piedmont uniforms?
We generally don't. Now, as you know, if you go on a hospital campus, I went to a doctor's appointment Tuesday and I walked in, it was Vanderbilt. I've went there, it was a sort of loyal since my wife went there for med school. And and this was an outpatient visit, just a quick in and out. And immediately they put that, tag on me, which was a little unusual. Like I was an inpatient. I was like, what are we doing here? So I think on a hospital campus, that can be confusing, but I think in our view is we want them to know we're the owner. We have, people to serve them, and we're proud of that. And we think we operate buildings very well. And we want to really, I do think it's a mix though, to your point about, it's almost like a private label approach to what we do. We're okay being kind of quiet and tucked in and really being an extension of a Wellstar.
Yeah.
But at the same time, we do have a lot of pride, and we want our staff to be very proud of what we do.
Right.
And we think, frankly, we do that better. It's partly why we know Wellstar wants to use us, because we do that particular service better than they would. Because if you think about it, back to you're running a hospital, the most important thing are those ORs, all the things those surgeons, the nurses, the staff need, the patients need in the rooms. And so the medical office, frankly, is probably less urgent and critical. So it's actually a nice thing to outsource.
I see.
So it actually helps to kind of divide that line. And
Yeah,
it depends on the complexity of the hospital. I mean, there are times where, like I said, the buildings are so intertwined, we're sharing central plant utilities with the hospital, and we're purchasing it from them. And we got to coordinate all these very complicated systems with them. So it does get a little tangled. But again, that's a good thing. That means you're an important building.
Well, the reason it's important is because another big change, the sea change in the industry, in the healthcare industry, is that there's a lot more consumer participation. You're choosing which hospital to go to, not your doctor. Now, when we were growing up, your doctor would say, you're going to Georgia Baptist, you're going to have this surgery, you're going to be admitted this day, and you're going to go home that day, period. And you say, okay. Now, if your doctor says, I'm sorry, but you have cancer, you need this surgery, you'd say, well, let me think about that. And I get all these ads from all these hospitals saying that we have the best. And I know I've heard of this place called Sloan Kettering in New York, and they're the best, and maybe I'll go there. So if the temperature is not right in the room, somebody's gonna have a bad impression of Wellstar. And they'll say, I think I'll go to somewhere else. So that's why I was wondering about the branding and the, and if the worst thing in the world would be for Wellstar is if the patient complains, even in the outpatient setting, especially in the outpatient setting, and the person says, well, we called the guys, but they're not here. Well, tell them to be there. Well, they don't work for us. That's awful.
Yeah.
Do you ever have that happen?
It's a very delicate balance that you want to make sure your team is super responsive. So I will say it's a skill set. And I'll give you a scope of it. I mentioned we were about 5 billion as of last year in market cap, and including debts or enterprise value, probably 6 billion or so. And today we have actually done a merger, so we're actually a fair bit bigger today. So we have 700 and something properties. And like I said, it's strewn across the whole US, but it's been a real evolution. I mentioned we evolved from, just basically collecting rents on buildings in the early 90s. We bought a services company in the mid 90s. Then we bought another, real estate investment trust in the late 90s. So it's been an evolution to sort of build into that capability, because I agree with you. And it takes time to build that skill set and then earn that trust from these health systems. And I think for us, and that's true of any business, you get that, if you're a startup and you get that first customer, well, you better deliver, right?
Yes.
You are going to hustle to deliver, because your reputation will be built on that. And it's hard for me to go back because I wasn't there in 93, but that's how you have to do it. And the other reality is, and it's true of hospitals, it's true of doctors, you're never going to be perfect. But if you try hard and you put every effort in and you show a great attitude and commitment, and obviously a competence, then, there will be some grace given if it's not perfect. But I think it takes years to develop that trust. And I think we've really come through with that and stand out in that regard.
Well, as a Scheller alum, you'll be pleased with the fact that the prevailing philosophy here is the Toyota production system, where if you're at 99.9% accurate, there's another 0.1% you can get. And so we're never satisfied. In my class, the only one thing you can't say, and that is, if it ain't broke, don't fix it. Don't say that. You get deducted points for that. So this is a fascinating sub-market or subfield within healthcare. I bet none of these students would have thought of that. They say, oh yeah, doctors and nurses. What else? Well, the numbers of what else is greater than the numbers of doctors and nurses in the entire industry. And here's an example of it. You're throwing around some big numbers. I think your merger actually became public since this was scheduled, Dory. I think that's right.
So it's been a complicated road. We announced it at the end of February,
I see.
but when it's two public companies. So we really have, in all those REITs I mentioned, 150 REITs, there's probably 16 or 17 healthcare specific REITs. And within that, there's 3 that do just medical office. So talk, as you said, quite a niche. And we were, I would say, the middle in size, but revered as the longest experience, the highest quality, longest tenured management, continuous management and so forth. So we had a good standing, and the biggest of the 3, they were probably, if we were 5 billion, they were 7 or 8 billion in size. And they had been a formidable competitor for us for some years. They were actually a private company for quite a few years, I think from 06 to 12, then they went public, and then, really started growing faster. And our view was, well, that would be interesting someday, because your comment about consolidation, the same is true in real estate. Consolidation is certainly occurring, and it's, again, all the same drivers that you would see in healthcare or any other industry. Consolidation, advantages of scale, whether that's operating efficiencies, cost efficiencies, or cost of capital, lower cost of capital. And so all of a sudden, last August, the CEO of our biggest competitor resigns abruptly. And doesn't sound like a big deal. If you've got your plans in place and you've got succession, and the board and the management team have done a good job of that, it should be a pretty quick move. As any good company with a good board, with good stewards, they should have a plan in place. And unfortunately, they sort of balked, and it's a very public event. It was a very surprising event. And there were a lot of questions around why, and it wasn't clear. There was always some suspicion of this particular person that, maybe it just wasn't known as being the most friendly of people, and had a lot of engagement with investors. So people had an awareness. And so everybody was suspicious. And it was really interesting to watch it unfold. Within a month or so, activist shareholders came in, a group called Elliott, which is, if you look at all at activist investors, they're probably at the top of the list, came in, basically took a position and said, you need to sell the company, because they didn't have a plan. They didn't have it ready to go. And I'm not saying the plan would have solved it, but it didn't help. So it put them, as I would say in the jargon, it put them in play. And of course, they ended up hiring JP Morgan to represent them and look at alternatives, and it resulted in a sale process. So that's what we went through. It was basically a year process almost. And so in February, we announced that. We ended up winning the exercise, competed against, the Blackstones of the world, really more private companies than even public companies. And I would say sometimes it's better to be lucky than good, but it helps to be good. But luck certainly plays a role. And I think that's true in your life and your career, and, being ready for those lucky opportunities and taking them. Yeah, and that's what this was.
We do a lot of cases, especially the professors of the practice. And succession planning is a theme throughout. And I've always been really high on that in my own career. I've been a CEO 3 times, and I've gotten good marks for my plan by the board. In fact, one board was too enthusiastic. They said
it's a little concerning sometimes.
Yeah, they said the best thing you ever did was the succession plan, and this guy's great. Well, all right, I was okay. But when they asked me to meet you and facilitate this session, I didn't know you, so I had to check you out. And I went to some of your classmates and got thumbs up, but I went to one of your competitors, who's a friend of mine, a golfing buddy of mine at Druid Hills Golf Club.
Who's that?
I'll tell you later. We don't need to put it on the the video, the recording. But he said, oh my goodness, they're the top dog in the whole industry. How did you get him? I said, I didn't. I don't even know him. But I know important people who do know how to get people. And so that's really interesting that well, a number of things. One, you're acquiring a larger competitor.
Yeah, so that is maybe a lost point that I didn't touch on was, we were buying a larger competitor. We had, market cap and valuations can be fuzzy. There's such big numbers, but we had 250 properties. They had 450. something like that. So we came together, nearly 800 properties. We're doing a little rationalization and selling some, but that is a lot for a team, even if you're good, to take on and to go from that scope. So it's a formidable challenge, but I think, obviously thankfully we are viewed as being really at the top of our game in that space, but it's still a lot, even when you're good.
Well, I think you're demonstrating so many things, and that's why these stories are so helpful to us as faculty members to show students the real world. We're not theoretical people. Everything we do as professors of practice is practical. I think I saw Bob here somewhere. He poked his head in, Bob Thomas. And Chuck Easley also poked his head in. I guess he saw me here and turned around and went back. But Chuck is a great guy. I wish he was here because I would introduce him. He is the fullback that charged over the line on the north end zone from the 3-yard line, ran over Refrigerator Perry, and scored the winning touchdown against Clemson in 1986. Remember that? I was there. I saw it. And that's the way I always introduce him, notwithstanding that he's a really rock star in his field of marketing and strategy. And so we've got some of those. Of course, I've mentioned Barry a couple of times and Bob. So we want you to come back.
I'd love to, yeah.
And speak to individual classes, because one of the richest parts is Q&A. So I think we have a microphone here. Let's ask some students to.
Thank you, Bill.
I can always count on
So
middle row there where it says 12. Student number
it's time
12.
for Q&A, and I just want to mention that we have is a hybrid event. So we have the virtual section, and I want to encourage our virtual audience to ask their questions using the Q&A chat box. So I think our first.
Iman? She's coming to you. You have your assistant there to hand you the microphone. Well done.
Okay, so I am actually a student in the School of Public Policy, so quite a different context perhaps than management or architecture. But one thing that I have been studying in terms of the intersection of healthcare and housing is, or at least the example that comes to mind, is the fact that Kaiser Permanente recently pledged about 400 million, I think, in terms of investing in affordable housing. Because I think, healthcare enterprises are starting to really put together the pieces that housing and healthcare are so connected. Do you see a future for companies like yours to be also invested in renting to enterprises or managing properties where perhaps people are staying there as a part of an affordable housing plan?
Yeah, it's an interesting area. We've just kind of run into this, I would say, in the last couple of years. And I think there's a reason for that. You're hearing a lot of employers run into this issue. Sometimes it's workforce housing, and that's probably the core of what we're running into in healthcare. And so we have over the years, Healthcare Realty as we've grown up and become bigger and had more scale, we've moved into bigger cities. We started out kind of just about anywhere in America. And we've moved to where healthcare has gone and where the population and demographics have gone, which is more urban. And so once you do that, you run into affordability. And whether that's, patients or that live in the community, or it's actual healthcare workers. And so we haven't actually invested in that yet. And I think we would be careful about it because our investors would say, we want you doing medical office. That's, the profile we want, the risk profile. But what we're finding is we not only do we buy buildings, we build buildings. We partner with health systems and we collaborate to how to evolve their outpatient strategy on their campus or even off campus. And a lot of times we're running into this, and the healthcare systems are saying, boy, we'd love this MOB, this medical office building, but we'd really like to have an area where we can add some affordable housing, workforce housing. So we're starting to engage with that, and more than likely we'll start with partners. We'll pull in people that are experts at that, which there are plenty, both private and public companies. And so we'll really probably like any good business, risk assessment, you joint venture first on something that you're not an expert at, and you pull in and you experiment. You do little case tests in different places, different markets. So we're looking at that exact scenario west of downtown Denver. We're on a great hospital campus there. And we've actually got about 14 acres right next to the hospital. And we're looking at, with them, expanding their outpatient campus, but also pulling in a piece that would have sort of mixed use, including affordable housing. And so we're just running into that more and more, the more urban we go. So I think it will be a bigger part of our picture. And to us, if we can help these health systems build stronger ecosystems and thriving areas around their hospitals, it's better for everybody there, working there, patients there. I mean, I always joke that if you want McDonald's, go to a hospital. They always seem to have a McDonald's in their cafeteria. Well, that's the worst idea, for healthy food. Nothing against McDonald's, but the idea is, if you can do things to help build a stronger, healthier community around that. And frankly, from a real estate standpoint, the more dense that area is, the more flourishing it is, the more value your real estate has. So it's sort of a win-win. So I think our view is we'll tiptoe into that, which is a trend you're seeing, whether it's tech space or healthcare space. It's really more about what I would say is the location, the urban locations that are more expensive. And I live, I love Atlanta, always loved it, thought I'd always end up there. And somehow I got to Nashville, and 20 something years later, I'm, still there, and I love it. And Nashville is growing like crazy. It's unbelievable. And so we're running into the same thing. We're talking with St. Thomas, a health system there, about the same thing. It's early stages, but we have those issues in a lot of our markets.
That's fascinating that you mentioned McDonald's. Children's Healthcare of Atlanta has 3 hospitals, and they used to all have McDonald's in them. And then Children's Healthcare, from a strategy standpoint, began to address childhood obesity, and they said something's not quite right here.
Yeah. Now they do have a lot of salads now.
They do, but nobody buys them. But so now McDonald's is out of all 3 of those hospitals, and amicably.
Chick-fil-A now.
Well, it's Home Depot. The new hospital, the $1.3 billion hospital, is named Arthur M. Blank Hospital. So expect to see doctors wearing orange aprons when they come in to visit the child.
And then Piedmont also has.
Yeah, that's Bernie Marcus, the other partner, the other founder.
Unbelievable, isn't it?
But they're all strategic relationships. So they're not embarrassing anybody. Your point is well taken that nothing against McDonald's. It was just an obvious, not a conflict of interest, but a conflict of
Purpose.
Yeah, exactly. So these students are all ready to come work for you.
Let's do it. I will say another comment about real estate that I think is interesting, and it's really in its infancy. And I would say we're so busy with our merger that we're very much in the beginning stages. But I think the analytical horsepower and all the, whether it's, AI or it's business analytics, all the things that are the hot areas that you guys are probably studying or applying, whether you're that major or you're something else. It's going to be a hotbed in real estate. There's all kinds of things that can really be applied. We're just starting to tiptoe into a few things, and I'm excited about it. So sometimes real estate can be viewed a little bit as an old school business, but it's a neat way to get involved with an industry that you really like. But maybe, and my wife, ended up becoming a doctor, but sometimes people go to pre-med or even go to medical school, and then it's not for them. I mean, I've met several sort of reformed doctors who've gotten into business and done quite well, lawyers, all kinds of folks like that. But I do think if you're interested in that, that's an area that's really just starting to take off, and you probably teach about that.
Well, I'm not going to let you recruit the doctors to become real estate people now.
We need the doctors.
That's part of the problem.
That's to me the biggest issue we face talking to investors when they talk about can you develop more buildings? Can you grow faster? And you say, well, the biggest challenge we have is we can't produce enough doctors and nurses quick enough.
Yeah. So we don't want to take the ones in practice away
Right.
and turn them into stockbrokers and stuff.
Hopefully you figured out before you go to medical school.
Yeah, that's right. I spent a lot of time working with my pre-med students. I usually have about 15 per semester. So are you sure? Are you positive? Before I give you this glowing recommendation that this is what you want to do. Lucas up there is a computer science major. And last semester, I had 3 of his fellow classmates in my healthcare management course. And one of them was a master's student, and they were all planning to go to Wall Street because they can make millions applying analytics to financial markets. And I'm pleased to say it's not me, it's the course, and it's the peers, the influence of the others in the course. all three of them changed their mind by the end of the semester and are going into healthcare. So we need you, and we need a lot of tech students in these non-traditional kind of industries. I mean, the Bay Area, of course, is turning out tons of good people, but how many students do you have? About 120? 54. So he's going to put 54 bright people out into the marketplace, but that's a drop in the bucket in your industry. And the same thing with the 13 pre-meds that I'll turn out this semester. Last semester, I teach a course in the spring. It's a practicum with Children's Healthcare of Atlanta, where 12 students that I handpick and invite to take the course and work for an entire semester on my project that children, it's kind of like a senior design, like your wife did. And the final exam is they put on their interview suits and go to the boardroom, and the CEO and her top staff sit there and say, what did you find? What do you think? What can you prove? What should we do? And lo and behold, they do it. And so last semester, the COO, Ron Friesen, tried to hire all 12 of them. I said, Ron, some of them are going to medical school. Can you wait, please, until they graduate and then hire them? And let them get their pediatrics, let them get to medical school, let them get their pediatric residency, a fellowship, and then hire them. But don't be so impatient. He said, well, I won't be here. I said, well, I won't either.
I'm glad I guess senior design, is that
Yeah,
still called that?
yeah.
So my wife did that. I remember she did a project with the CDC, her team, and that's an invaluable experience. The other thing I was going to mention that I did that was invaluable was the co-op program. And how many of you or anybody doing the co-op program? Okay.
It just kind of lost steam because of the change from the shift from quarters to semesters.
Yeah,
it's not as easy
I
now.
wondered about that. 'Cause with 4 quarters in a year, it made it
Yeah,
pretty
my
easy.
lady friend who just celebrated her birthday Monday is a CHE from Georgia Tech. She's a little younger than me, more than 3 years, as you mentioned with your wife. But she did co-op and tells great stories about it, and it helped her become very successful. She started a medical device business and sold it, and it's doing quite well.
Well, so it's interesting because I mentioned the architecture influence to start, and that had the idea of real estate. And then I ended up co-oping, and I think I did maybe 6 quarters, so call it a year and a half.
That's what you do.
And I did that with a company based here, it's a group called Medical Management Associates, and they consult with health systems and physician groups. So
I know them well.
yeah, and Charlie Thomason, and actually, I sort of went off on my career for 20 years, and we were looking for some expertise in healthcare for our board, and so we actually recruited one of my old colleagues that I hadn't seen in 20 years, a guy named Peter Lyle, who was an IE from Georgia Tech.
Good.
So he's on our board. I have to get a little more Georgia Tech representation because in Nashville it's very SEC centered, so it's a little.
Bless their hearts.
We have to hang on to our ACC and Georgia Tech roots, but we've got a couple. But that was a phenomenal experience, and frankly, I grew up in the military healthcare system, so I was very naive how the healthcare market worked. I just went where they told me to go. It was a little bit like the Kaiser model,
Yeah,
but, government run.
Well, I'm just going to tell you, just saying, look around here, Google, Microsoft, Facebook, all these companies, one of NCR, Norfolk Southern, they all want to be here. The headquarters of Blue Cross Blue Shield is next door. They're here because of them, not because of us. They're here because of these students. So if you decide to come recruit Georgia Tech students, especially Scheller students, you'll be in good company.
Yeah, thank you, Todd. We have 2 more questions, and I hope you're able to answer it just in time. And we have one online. Sarah, can you?
Yeah, I think you actually addressed this in part, but if you wanted to add anything, Mia was asking, how have you seen or how do you foresee emerging technology trends impacting the healthcare and real estate industry? So I know you're talking about AI and, ways that those are going to be playing a part, but if you wanted to just add any additional thoughts.
It does start with people, even though it's about technology. It's about getting that talent, and it's kind of coming off what Bill just said. I mean, you really have to pull in the talent, and I think for us, we're just starting, that process. We just pulled in a new head of technology and tech services, we call it. Everybody's got an IT department, but a guy that really has a background. He was a career military guy, went to the Naval Academy of Computer Science, Computer Engineering background, and really helping us bring it along. So it starts with people. One of the nice things about this merger that we've done, so I mentioned we announced it in February, we closed it in July. And so now we're working on the integration, and we're picking up some great talent and skill sets. So we've got some young people there, and they were a little ahead of us on technology because they had been forced through being a bigger company with scale to invest in some more technology. So it's a combination of people, getting the right people on the bus and figuring out, what are the right tools and what are the things to invest in. And so again, it's a long road, but we're seeing, I always think of AI as being something that can go in and really crunch the numbers and tell you the trends and, figure it all out for you, which is a naive assumption. But real estate is all about leases, and these are legal documents that are a little painful to spend your time in, but they're the lifeblood of producing your revenue. We're actually have an AI tool now that we're using that goes in and basically summarizes all the key elements of that lease for you, automated. It's crawling through our systems and documenting 8,000 leases for us. It's phenomenal. So, think about the savings and efficiency that come from that versus hiring, 500 lawyers to do that. It's amazing.
So it sounds like you need Lucas, and it sounds like you need a public policy person. You could be a real market leader by being the first REIT to have a public policy expert on your team.
There you go.
Yeah, our second question is from an MBA student, and
hello, thank you, Todd, for coming. I had a quick question regarding building off the earlier public policy question about, as say, for example, Atlanta becomes more urban, do you anticipate that with increased density, healthcare campuses will still be very large campuses, or do you anticipate a lot of smaller buildings scattered throughout a city? And then to build off that, do you anticipate it being buildings dedicated entirely to healthcare, or maybe more like a Tokyo type where 1 or 2 floors are medical office space and the rest are multifamily? And how would that impact, I guess, your business model?
Sure. It's a great question. Did you do some reading about our company? Because that's certainly a key issue that has been happening in healthcare, something we've been evolving with. We were known really as that hospital campus centric company. We would really, as we discussed earlier, we would try to invest alongside the hospital in their on-campus medical office buildings. But that trend among healthcare providers of decentralizing a bit, sort of decanting from the hospital out into the community to expand the market share, have more points of access, out to the consumer-driven model. That's been alive and well for a long time. It was actually going on in different forms, even in the 90s, but it's really robust now. But I think the answer to your question is really both. You will continue to see very large hospitals. I don't think you'll see as many brand new hospitals being built, that are mega hospitals, but they will continue to evolve and expand upon the ones that are there, whether it's Emory or Wellstar, Piedmont, whoever it might be. And you're seeing that. There's many examples, these huge towers that are in centers of excellence that are being added. So you'll see both, and we'll invest in both. We do like that on-campus piece because if a hospital is investing $1 billion or they have donors creating these centers that are $1 billion investment, well, that's not going anywhere anytime soon. There was a little bit of a trend among investors that were worried that hospitals were starting to, before COVID, it was kind of like, oh, well, the hospital's going away. These are just trauma centers and everything's going off campus. And there's some truth to that a lot more was going off campus, and it is more convenient if you're just going for your well visit. But I think COVID sort of reminded everybody how critical hospitals are. Again, we don't love to go there unless we absolutely have to, but they get full quickly. I was talking to somebody recently that had to go to the hospital in Atlanta, a relative of a colleague, and said they went to the ER and the hospital was full. This is just a suburban hospital. It was full and they had to wait forever. That's a little bit there's a capacity issue. There's a little bit of an issue of where is the capacity. So you've seen, again, with the demographic populations moving, you see rural hospitals that struggle because they don't have the population and the volume to fit their capacity, and they don't have the talent there that they need. So it is all shifting more urban, and that's been an evolution that we've followed as well. But we'll definitely invest in both, urban centers, but also out in those communities. Good question.